Welcome everyone. Thank you for joining us in today's webinar, Understanding Gender Differences in Work-Related Health Outcomes. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness Institute, and I'll be moderating today's webinar. We would like to thank our academic team and our 9 founding partner organizations in the Harnessing Talent project. Harnessing Talent, Alliance for Recruiting and Retaining Canadians with Disabilities and Mental Health Challenges, is a 3-year project funded by Employment and Social Development Canada. This webinar is made possible through the support of ESDC, as well as donations and memberships to WWI. We thank our advisory committee and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing, any comments you may have, and any questions related to the webinar. We will collect questions submitted throughout the webinar and follow it with a Q&A based on the questions submitted. Please note that the Work Wellness Institute is recognized by the Society for Human Resource Management, SHRM, to offer professional development credits. This program is valid for 1 PDC for SHRM CP or SHRM SCP. Our institute also offers accreditation recognized by VRA Canada. If you're a WWI member or a VRA Canada member, you receive free certificates of attendance. Otherwise, there's a $15 administration fee. We're very excited to welcome Dr. Robert Macpherson today. Dr. Robert Macpherson is a research associate with the Partnership for Work, Health and Safety, a partnership between WorkSafe BC and the University of British Columbia. Robert leads a program of comparative research on return to work following work-related injury and illness, and also conducts research on the effectiveness of the certification of recognition on reducing workplace injuries and the effectiveness of workplace inspections on promoting changes in workplace hazard management and reducing workplace injuries. Robert, thank you so much for presenting this webinar today. We certainly appreciate your time. I will hand you the floor without further ado.
Great. Thanks very much for the introduction. Thank you all for attending this webinar and giving me this opportunity to speak a little bit about understanding gender-based differences in work-related health outcomes. So as mentioned in the kind of introduction there, I've worked on a broad range of research topics in the area of work and health. And in the area of gender and work and health, I've done research on work disability. But given the kind of broad kind of professional backgrounds of the audience today and the time I have to present, I thought it would be a good opportunity to kind of, instead of focusing on one specific study I worked on, to kind of give an overview of how we can understand gender-based differences in various different aspects of work-related health. So just take this opportunity just to talk a little bit more about the Partnership for Work, Health and Safety. So as stated, we are a partnership between the Workers' Compensation Board of British Columbia and the University of British Columbia. We are a research unit in the School of Population and Public Health. And we conduct a lot of research on work and health. The majority of it is based on working with large administrative databases, such as workers' compensation claims, as well as linkages to health administrative records. And we do that through our data provider, Population Data BC. And we are a diverse group of faculty, staff, and students. And we collaborate with researchers across Canada and internationally with the Institute for Work and Health in Toronto, as well as the Insurance Work and Health Research Group in Monash University in Australia, as well as the Occupational Cancer Research Centre and CareX Canada. A lot of our research is conducted in BC and funded by WorkSafe BC, but we also conduct a variety of projects looking at different provinces across Canada and internationally. Our research is funded by various workers' compensation boards and research councils as well. And in the area of gender, we tend to have quite a strong element of gender analysis within our studies, and part of that is also due to our co-director, Professor Mika Kuhorn, who is a gender chair in work and health. So you'll see her name pop up in quite a few of the studies which I'll be talking about today. So just to kind of give you an overview of where I'll be going with this webinar today, I want us to start off by thinking about what do we mean by gender and how that may differ compared to sex. I then want to talk about why we should be studying gender and sex-based differences in work-related health outcomes. And to do that, I will be walking through kind of 3 different kind of examples of work and health. So starting off with thinking about workplace injuries and disorders, and then thinking more about work disability and return to work, and then moving into differences in healthcare access between men and women. And then hopefully this will help us lead into a discussion in terms of what the implications are for the policy and practice from these findings. So this slide is from the Canadian Institute of Health Research. So they're actually they have a fantastic resource because they've got the Institute for Gender and Health. And if you're interested in finding some more examples of gender and sex-based differences in health, they have a website which I'd highly recommend going to. As stated on the website, every cell is sex and every person is gendered, and our sex and gender can influence the risk of us developing certain diseases, how well we respond to medical treatments, as well as how often we seek care. However, the terms sex and gender are often used interchangeably despite having different meanings. So simply put, sex is best understood as a kind of set of biological attributes in humans and animals. It's a biological construct which encompasses things like hormones, genes, anatomy, and physiology. And for our health, it affects prevalence of particular conditions, our course of treatment, and health conditions and diseases. In contrast to sex, gender is best seen more as a kind of social construction dealing with roles, behaviors, and expressions of girls, women, boys, men, gender, and sexually diverse people. So it deals with roles, identities, relations. It's linked to power and social and economic status. It's culturally specific and temporal. It can change over time. And compared to sex, it's not just a simple binary of male versus female, man versus women. It can be seen across a whole wide spectrum. But I'll say up front, the way I'll be presenting sex and gender-based differences today will tend to focus on comparisons between men and women, and part of the fact of that is that we're relying on data that's collected in administrative records or surveys, which tends to only include those 2 types of categories. So I'm just acknowledging that up front here. So why should we be interested in gender and sex and work and health? Well, hopefully we all want to live in a society that's equal and equitable, regardless of whatever your gender and sexual orientation is. Everyone should live healthy and happy lives. We think of, in terms of workforce productivity, women make up a large and growing proportion of our workforce. So to give you an example, in Canada, in the mid-70s, around 37% of the workforce was female. But then by 2019, this was up to about 47%. So if there's areas of our health related to work that are being differentially affected, that can pose a big problem for our workforce. Then we can think about the kind of broader social and economic costs. So my background is kind of with thinking about how things fit within the workers' compensation context. But to give you an idea, across Canada, there was in 2018 there was 264,000 lost time injury claims, and just around 160,000 of them were men compared to 100,000 for women. But thinking more severely in terms of workplace fatalities, there was 1,027 fatalities in the same year, and 997 of them were for men compared to only 30 for women. So when you think of the impact that workplace incidents have on workers themselves, there's also an impact on their families, their employers, the workers' compensation and healthcare systems, and society overall. So we want to try and prevent injuries and improve work-related health. Another reason why we should be looking at sex and gender is that we're still learning more about it, because traditionally in epidemiological research, the focus was on male worker populations, or there was studies on populations, but there wasn't interest in sex, whether sex and gender, and whether risk factors differed by sex and gender. However, this is actually something that is changing. So yeah, I'll move on. So there are a range of different aspects of our working lives in which gender and sex may differentially impact our health. First, we can start off with kind of sex-based biological differences. We're kind of assigned at birth. So there's sex-based differences, which mean there are physiological differences as to why a man or a woman may be prone to a particular injury in their working life, and vice versa. But what contributes to this is also the job characteristics we have. And it's well known that the labour market is highly segregated, both in terms of industry and occupational hierarchy. And although there have been improvements to try and create a more integrated and more equal workforce, the fact is that women and men typically occupy different sectors in the labour market, and that puts them at different risks and exposures for injury and poor health. There's also income disparity between men and women. So this is less likely to have an impact in terms of your likelihood of having an injury, but it could play a part in terms of your likelihood of filing a claim or going back to work early due to the income you're missing out on and being on wage loss benefits. Then there's also our work-life balance, and outside of our work, the domestic responsibilities. And surveys in Canada show that actually women are still spending more hours on average than men and doing domestic duties. So in terms of causing fatigue and causing aggravation of pre-existing injuries, this is something where it could potentially be impacting women more than men. And lastly, here I've got the experience of healthcare and workers' compensation systems. So there's a lot of evidence which suggests that the care-seeking behaviour differs between men and women. And there's also growing evidence of different experiences of men and women navigating the workers' compensation and healthcare systems. So I'll be talking about that a bit later on today. So it's just to give you a kind of snapshot of how things look here in British Columbia. There's about 52% of the employed population are men compared to 48% women. However, within the injured worker population, 62% are males, men, and 38% are women. And to give you an idea of how this is changing over time, you can see that around 35% of the female claimants, and this has been growing over a 10-year period to just over 38%. And this includes like claimants for short-term, long-term, and work-related death benefits during these years. Narrowing down on serious injuries, which are claims with serious medical conditions with recovery periods of 50 days or more, including workplace fatalities, you can see that there's a much higher proportion of male claimants here, but that is decreasing over time, whereas the female claimants is increasing over time. So this moves me into the kind of first area of work-related health that I'm interested in talking about, and this workplace injuries and disorders. So in general, women experience and report more work-related musculoskeletal pain and disorders. And the mechanisms that explain these differences are multifactorial. Part of it could be due to the gender division of labour, with men and women occupying different occupations and having different exposures and risks. However, there is a growing body of evidence to show that even when men or women working in the same occupations and doing the same tasks, that there's a higher reporting of symptoms among women than men. So this is just a couple of examples I have here. Study in 2004 in applied ergonomics, in which they compared work technique and self-reported musculoskeletal symptoms between men and women performing the same tasks within the metal industry. And they found that women worked more frequently during longer times with their hands above their shoulder height, and there's a higher proportion of women reporting shoulder problems. The authors of that study stated that this could be due to workplace design factors, as well as women more likely to report time doing household activities than men. So you can see there it's kind of like a combination of sex-based differences and gender-based differences, because the sex-based differences can tie in with the workplace design, whereas gender is more to do with gender norms and what's going on in the household. And a more recent study in the American Journal of Industrial Medicine, they were focusing on custodians, and they found that gender was significantly associated with musculoskeletal symptoms, and actually the prevalence of the symptoms was approximately 50% higher for women than men, regardless of the task performed. So around the end of last year, we were approached by WorkSafe BC to conduct a gender-based analysis of activity-related soft tissue disorders, or ASTDs. So by ASTDs, these are disorders of extremities of the arms and legs involving muscles, tendons, and ligaments. These are generally caused or aggravated by overuse, repetitive activities, exposure to mechanical vibrations. So this is some of the results from the research brief we conducted. The overall objective was to examine gender and sex-based differences in the rates of accepted short-term disability claims by time period, occupation, and type of disorder. So to do this, we used data from WorkSafe BC claims, as well as labour force survey estimates for the BC employed population. We used this to calculate standardised rates of ASTDs per 1,000 workers. And the time period we covered was 3 5-year periods from 2003 to 7, all the way up to 2013 and 2017. Age was categorized in 10-year groupings, and we used the National Occupational Classification 2006 categories. So in total, this produced cohort with 9,500 ASTD claims for men, compared to 6,500 for women. So there was a higher number of claims among men than women. But when we start to look at the rates, here we do the rates separately by different age groups and over time. And the kind of main observations from this is that the rates have been decreasing over time, with the exception of the older age group, 55 to 64. The rate among younger workers were generally higher for men than they were for women, especially in the last 2 time periods. And rates among age 45 to 54 were higher among women than men. But this doesn't take into account the type of ASTD or the occupational composition. So in this slide, this looks at how the patterns differ by the disorder type, looking at tendinitis, bursitis, and carpal tunnel. And overall, there's generally quite small differences, with maybe the exception of carpal tunnel, which is notably higher among men. But across all of the conditions, the rates are higher among men and women. But this doesn't take into account occupation. It does take into account age composition. So when we look at occupation specific rates, that's where we really see large differences here. So, for example, 27 of every 1,000 female workers working in processing, manufacturing, and utilities were compensated for an ASTD in 2003 to 2007. Whereas in contrast, for males, this is more like just over 15. And we can see that there's changes over time, and that we only show here in the slide sort of 3 of the main occupational groups, but when we're drilling down by occupation, we see this pattern across various different occupation groups. So overall, the kind of main points from this example is that although the number of ASTD claims are higher for men than women, the rate of ASTDs for the most part is higher for women than men. This finding does support existing research evidence, such as the kind of studies I cited before. But we do see some convergence over time, which does suggest that there's been some improvements in prevention measures, particularly in sectors that are not commonly occupied by female workers. So I'll now move on to an area which is more my expertise, which is in work disability research and return to work. Compared to research on workplace injuries and rates of injuries, there's a smaller but growing body of research which looks at disability outcomes by gender and sex, although these have tended to look at more like long-term disability and transitions from long-term disability into disability pension. But from the handful of studies which I refer to here, we do see that there are sometimes differences observed even after accounting for various individual characteristics, So a study in the Netherlands found that although there was no differences in return to work, they did find differences in lasting return to work. And then there's a range of studies conducted in the province of Quebec by Lederer and colleagues, which have been very helpful for our study. And they found that although there was maybe no differences for the shorter duration claims, the longer people are on claim, you start to see differences, especially after 12 months, with men transitioning off benefits slower than women. A lot of the studies have tended to look at single jurisdictions. However, there's a couple of studies which look at whether this gender or sex-based difference is evident across provinces or in states. So one of the studies in Australia, for example, they found that women were less likely to transition off benefits. And then there's a study in the United States using private healthcare insurance, which they found that women were associated with just under 2 more days of disability after accounting for a variety of individual and state level differences in compensation. However, it's important to note that there's limitations to those studies and that differences in gender may vary across jurisdiction because of differences in healthcare, workers' compensation systems, as well as values such as gender norms. So this takes me to another of our studies here. So this is part of a larger comparative return to work project looking at return to work across the provinces of British Columbia, Manitoba, and Ontario. But this was a good opportunity for us to ask a question of whether gender differences in work disability duration were consistent by jurisdiction and whether they're consistent by the duration or the length of time an individual is injured. So to do this, we use claim level data from the 3 provinces of British Columbia, Manitoba, and Ontario. We created comparable cohorts based on accepted claims with at least 1 disability day paid. We had workers that had to be over 15 years at the time of injury, injured between 2007 and 11. And we focused on work-related injuries as opposed to like occupational diseases where there's more challenges in harmonizing the data across the provinces. We analyzed this using time to event analysis. So basically looking at the length of time and the likelihood of someone transitioning off disability benefits. So our time component here is the cumulative disability days in which they're paid benefits, and then the event would be the likelihood of transitioning off these benefits within the first year of injury. So this graph just shows you the results from BC kind of descriptively. So this is a Kaplan-Meier graph which shows the proportion of claims still receiving disability benefits over time between men and women. And the sort of key observations to make here is that you see that the majority of the claims are no longer receiving benefits at 1 year of the injury. And although the lines are very close, indicating there's maybe not too much of a gender difference, the majority of the rate at which male claimants are transitioning off benefits is faster than females up until around 50 days, after which it switches. But bearing in mind, this doesn't take into account differences in age, injury type, indoor occupation, for example. So this slide can be a little bit complicated, but basically it's the results from the regression models which control for these individual level factors. And instead of looking at the proportion still on claim, this is actually looking at the likelihood of women compared to men of transitioning off disability benefits, depending on the length of time that they are receiving them. So if you look at the vertical axis is the hazard ratio. Just a helpful note is that the line is of women relative to men, and so when it's below 1, that indicates that women are less likely to transition off disability benefits compared to men if they are still receiving benefits at this time. So the main observation is that, kind of like the survival graph in the previous slide, that men are transitioning off disability benefits faster than women for shorter duration claims. So up until about two months, after which that's when women are transitioning off disability benefits at a faster rate than men, up until around the 200-day mark when it flips around again. And when we show the results from all 3 of the provinces, we see that there are some similarities and differences. We see that there's a significant difference between men and women over time, and that this is evident in all jurisdictions, but the actual kind of magnitude of the differences changes over time. So it's much larger difference in BC for the short claims. And then with the exception of Ontario for claims of maybe 1 to 3 days where women are transitioning faster than men at that point. When we then focus in on injury types, we also see consistency to this pattern. So this slide is just for backstrain injuries, and we can see that again, we see this kind of same pattern with men transitioning faster than women, when women transitioning faster than men, and then at the end of it, it's changing around again. So in summary, there are significant differences between men and women transitioning off disability benefits, and these differences vary depending on how long a worker is receiving benefits. But what's causing this time varying difference between men and women? Unfortunately, this is something that we can't fully address in our paper due to limitations in our data. But a couple of the hypotheses we have is that the negative impacts of being unable to work or being absent for work may lead to psychological problems that are greater among men and women. Our cohort focused just on work-related injuries, but it's possible that if you had access to data with secondary conditions, you might see that the actual psychological impacts are worse for men over time than women. Another factor to consider is also whether we are fully capturing the effect of injury severity. We adjust for occupation, injury, and injury type, but it may be the case that there's differences in the severity of injury and that driving some of these differences over time. And what is driving some of the differences by jurisdiction? This is something which may be due to work industry composition, as well as differences in compensation systems and healthcare systems. But what we know is, based on this evidence and other evidence published on gender differences in return to work, is that perhaps we should be tailoring prevention and rehabilitation interventions to meet the specific needs of men and women. So I'll move on now to the sort of third or last of the kind of case study examples. This is more to focus on healthcare services and access to healthcare or recommendations for specific healthcare and how this may be different between male and female workers. So a kind of inspiring study for us at the partnership was this, conducted in, published in 2008 in the Canadian Medical Association Journal. And this study looks at the effect of patient sex on physicians' recommendation for a particular type of surgery, so total knee arthroplasty. So the kind of premise of this study was that there was a reported underuse of women relative to men who were appropriate candidates for this procedure, and that when consulting physicians, the physicians reported that sex had no bearing on their decision to recommend this procedure or not. So the authors wanted to actually test whether this was actually true in clinical practice. And so to do this, they had two standardized patients with similar conditions, with the only variation being their sex. And they had 71 physicians, so 38 of them were family physicians with 33 orthopedic surgeons. So the patients recorded the recommendations that they received from the physicians about this procedure. And the key findings were that in total, 42% of the physicians recommended the total knee arthroplasty to males but not females, and that 8% of the physicians recommended the procedure to females but not the male. And then in the regression model, the odds of orthopedic surgeon recommendation was 22 times higher for males than females. And although it wasn't quite as large, there was the recommendation from family physicians was 2 times higher for males and females. So the kind of take-home message from this is that physicians are more likely to recommend this type of procedure to men than women, but also suggests that there's a gender bias, and that can contribute to sex-based disparity in the rate of the use among this procedure. So this inspired my colleagues, Andrea Jones, Mika Kuhorn, and Chris McLeod, to conduct a study within the working population context. So rather than general public population who are injured, looking at injured workers. So the objective of this was to examine gender differences in surgery among workers in BC with accepted workers' compensation claims for musculoskeletal injury. For this, he used WorkSafe BC claims data linked with Ministry of Health records. They created a study population based on accepted lost time claims with 3 different conditions, so knee meniscal tear, rotator cuff tear, thoracic lumbar, intervertebral disc displacement, and for injuries that occurred between May 2009 and December 2010. And again, time to event analysis was used, but in this case, instead of time being the time on claim, it's the time or the wait time for surgery. So time between injury and surgery date, with the event being the surgery taking place. So this is just a result from the adjusted hazard ratio. So similarly to the previous slide with my own work, the hazard ratio interpreted here is with reference to men. So a hazard ratio of less than 1 indicates a lower likelihood of receiving surgery compared to men. And what you can see here is that for knee meniscal tears, the hazard ratio of 0.87 suggests that women have a 13% lower likelihood of receiving knee meniscal tear surgery compared to men, even after accounting for differences in age and occupation. When looking at rotator cuff tears, the actual difference is even greater. So we see this is like a 0.35 of a difference. So a 65% lower likelihood of women receiving rotator cuff tear surgery. And then for intervertebral disc displacement, you see a 46% lower likelihood of women receiving this treatment than men. So these findings are in agreement with literature from general populations. Women are generally less likely to receive surgery. But this expands on existing knowledge base because it looks at injured worker population and different types of injuries. So the existing research, I think, has looked just at knee replacement and hip surgery, whereas this looks at sort of shoulder and back surgeries as well. The other thing to add is that after restricting the analysis to surgery that was paid for by WorkSafe BC, the probability of women receiving the surgery was still lower. So this demonstrates that a gender bias is not because of surgeries paid for in the public healthcare system. And although this thing suggests that there's gender bias in terms of the likelihood of receiving surgery, an interesting discussion point here is whether this is actually a good thing or not, because the medical evidence regarding whether certain treatments require surgery is not so clear, particularly with back surgery. So the fact that men are receiving back surgery at a much greater probability than women may not be a good thing. So actually, so the take-home messages from the kind of 3 examples that I've given you here is that there is growing evidence of gender and sex-based differences in work-related health outcomes. So we see that in terms of the likelihood of having musculoskeletal symptoms, having claims accepted, but we also see it in terms of various disability outcomes, whether it's your likelihood of transitioning off long-term disability, whether it's your likelihood of returning or lasting return to work. And there's also evidence of differences within healthcare. The examples I've showed you there was within surgery, but there's also various studies which show that care-seeking behavior differs between men and women too. So the other take-home message is that we should be making greater efforts to reduce bias in how conditions are assessed. So because men and women present different symptoms or conditions differently, this may be impacting whether they're being recommended or offered specific types of treatment. So medical professionals need to be conscious of the differences in the way conditions are being portrayed, and also whether they're being offered the treatments. We should also think about within the context of compensated injuries, it may be the case that we need to think more about using different strategies and accommodations to meet the different needs of men and women when they're injured. One of the things in one of the studies in Quebec, they looked at predictors of return to work and how they differed between men and women. And one of the things they found was that the effect of age was not the same for men and women, that there was a kind of continuous lower likelihood of return to work for women by age, whereas men, it was at a certain cut point of being 55 and above, and that the effect of children at home had a bigger impact among women compared to men, and that awareness of workplace health and safety programs was a significant factor for women, but it wasn't for men. So perhaps that's something that's an example of what can be improved to try and reduce some of the differences in return to work. Yeah, and then linking in with the last slide, what was I going to say here? We need to have a greater awareness of kind of a work-life balance. So we know that there's, we know that there's differences in terms of the actual household duties between men and women and how this can interact with their work-related health. So as opposed to just making changes in the workplace, focusing on injury prevention and rehabilitation at the workplace, we need to be conscious of how this interacts with household responsibilities as well. And I managed to talk so far without mentioning COVID-19, but I mean, we're living in a global pandemic, and this is having a massive impact on our work and health. And it has a potential to worsen gender and sex-based differences in work-related health too. So this is just a kind of screenshot from an article published in The Guardian earlier this year, but it just highlights one of many different areas in which could be contributing to inequalities in terms of risk of COVID-19. So, for example, the personal protective equipment, PPE, has been typically designed for males, and it's not going to be fitting women to the same extent due to anatomical differences. So this is kind of like a sex-based difference right here. For example, in the headline, PPE is made for a 6'3" rugby player. Health professionals and experts say this poorly fitting equipment is risking lives of female workers. So gender and sex-based differences in exposure to COVID transmission is going to be a major topic going forward, due to just things like the division of labour, with more women working in healthcare than men, and healthcare workers being currently at greater risk of exposure than other sectors. There's also things to think about with, like school closures and daycare closures, and how that's going to interact with the duties outside of your work, and whether people can actually keep their jobs, whether they can, how they're going to be returning to work. This is something where we may be expecting differences between men and women over time. And then there's also things to consider, like a lot of the research which has been conducted on COVID-19 and worker health is just in terms of transmission. We haven't yet really had a chance to see the impacts that it can have on people who are already injured due to different, not specifically due to COVID. So something which we may see big differences is in terms of everyone working from home, the ergonomics of your workplace at home, and how that might be impacting women more than men. We know that kind of upper body musculoskeletal conditions are more common among women than men. So this is one area which we may see bigger differences occurring due to COVID. So yeah, these are just some of the many different areas in which COVID may be driving differences in work-related health. And I think I'd like to stop here, and I'm sure you'll have your own questions, but these are some of the questions I thought might be interesting to ask the audience, given the diverse professional backgrounds that you all have. So one thing is, are there gender and sex-specific policies or practices in terms of workplace injury prevention or disability management in your organization? Was there a particular study which I've talked about which resonated with you in your job role? And also, has any of this made you think differently in terms of your position, and whether that could contribute to any biases in decisions and impact worker health? And lastly, I mean, are there measures that your workplace can introduce to help reduce some of these differences? So I will stop right there.
Thank you so much, Robert. I'll just ask our audience to input their comments and answers in the question box. I'll give you a few seconds for you to answer, and I'll be reading them out loud if there are any.
Okay, thank you.
So it seems we have a lot of answers for the first question, and that nobody's aware about their gender, sex-specific policies and practices in their workplace, which majorly highlights the problem. Another comment is, it's really an interesting presentation. In my work, we aim to make policies about accommodation to make equal access.
Yeah, that's something I've been interested in learning more, because a lot of my work I've been presenting more to kind of an academic audience, and it's great to get more insight from kind of practitioners, whether vocational rehabilitation or disability management, because I don't see examples of sex or gender specific policies or practices published on websites, but in a lot of academic studies, there's often recommendations to have this, but this may introduce problems as well as solve problems, because of maybe they're too narrow, just thinking of what's specific for men versus women. So it's interesting. I'm kind of not surprised to hear that there's not many people are not aware of gender or sex specific policies or practices in their organizations.
Absolutely. So we'll leave these questions with our audience for them to reflect on this. In the meantime, maybe we can jump to the Q&A session, if you don't mind, Robert.
Yeah. Excellent. Yeah.
Perfect. So the first question we have is, can you elaborate on your hypotheses on and the suspected mental health and psychological impacts leading to this time varying difference between men and women transition of disability benefits?
Yes. Yeah, this is something which the kind of mental health aspect of it is something which we're inspired by other studies which looked at more like the impact of long-term unemployment on health and how that differed between men and women. So there's a study in Spain which found that the impact of being away from work or being unemployed had a more negative impact in terms of mental health of men than women. So that, although this is something we weren't able to actually examine in our study, it's something which I think could potentially be looked at if you did a linkage study, not only using what was the injury that they were compensated for in the workers' compensation system, but linking it to the sort of the health records, the Ministry of Health records. You could actually try and identify and tease out whether there is a greater incidence of kind of mental health conditions as a result of the injury for men compared to women. But I think in terms of maybe trying to explain a little bit more of why we might suspect that is maybe more to do with the kind of gender aspect of it, with masculinity and kind of the male breadwinner. So the actual role of being able to work and provide for a family is more important to the man, or like it's more being unable to do that is going to have a bigger impact on men and women. So that's something to hypothesize there.
Thank you so much, Robert. Our next question is, if there are no gender or sex-based policies in place for injury prevention in your organization, how could you approach your employer about creating them?
That's a good question. Well, I guess I'm wondering if, going to your employer with evidence, research evidence, which suggests that there are sex and gender-based differences. So if it was like, say, if it was like a injury prevention policy, and you're working in a workplace where ergonomically the workplace is kind of tailored more towards men and women, then if you can provide evidence from research which suggests that because of these differences in workplace factors, that they're going to put, say, women more at risk of an injury than men, perhaps that's something you could do. That's just one example. It's a tricky question. I'll have to think about that a bit longer.
Sounds good, and we can share any further insight you have on our page later on. Thank you, Robert. And our next question is, are there any factors, accommodations, or guidelines that could improve the transition of work disability that you are aware of?
Well, I think in terms of gradual return to work is maybe something which could improve the transition of work disability. But the issue we have there, especially in gender or sex differences, is that the ability to provide work accommodation differs by the sectors that we're in. So So for men, more men are working in, say, like the construction sector, but the ability to actually return to work in modified hours, modified duties is more challenging than it might be for women that are working in, say, like in the healthcare sector.
Thank you.
Yeah.
Thank you, Robert. And we can move to the next question. So what studies or data should we be looking at in order to find out about the reasons causing a time varying difference between men and women? And what would be the next steps?
Well, I think greater knowledge of the injury or condition that workers have, because, like I said, one of the limitations is being able to account for the kind of severity. So, if there's more information in terms of particular types of injuries, when you expect a kind of recovery to occur, and then, I mean, in terms of next steps, another thing would be also whether there's particular like times within the kind of systems, the case management systems, or at which certain things happen. You know, I don't know if there's a certain threshold point when. Yeah, sorry, I'm trying to think how best to answer this one.
That's completely fine. Those are very particular questions, very specific questions. So I'm sure if you need some time, we can or if you have further insights, as I said, we can just include that on our page.
Yeah.
Another question our audience had was, what type of, you mentioned some efforts should be made in order to help reduce that bias between men and women. So what type of efforts do you think would help reduce that bias in how conditions are assessed?
Yeah, I think education is going to be a major part of that. So I think some of these decisions are being made, say by physicians, for example. Some of them are based on kind of unconscious biases that they may have just based on how they've treated patients in the past, but also just on their understanding of the kind of research evidence. I think if there's improvements in terms of the education, whether it's actually trying to approach some of these physicians and show them kind of evidence of how they've been assigning or recommending specific treatments and how that differs by sex and gender, then I think that's one way in which we could try and address this problem. So yeah, education, I think, that's the thing that comes to mind for me there.
Thank you, Robert. Another question we had was, what are the main barriers to assessing those differences between men and women on the workplace?
I think one of the barriers is just actually the like what information we have available to us. So we try our best to kind of try and separate our analysis by male and females, for example, but we often don't have access to other information outside of their claim. So when there's ways to kind of link in information in terms of say like household dependencies, and whether there's actual more information in terms of how someone identifies himself, that's going to definitely help us address some of these issues in terms of the barriers and how they may differ between sexual and gender identities. And yeah, so I think that's one of the main barriers I see is like a kind of, and we're also, a lot of the research that I conduct and a lot of the other people conduct is based on administrative data. So we need to actually start collecting more information through surveys or other kind of qualitative data collection methods to actually hear from the workers themselves, as opposed to trying to interpret what may be going on just based on some of the other factors that we see in administrative records.
Makes sense. Another question is, I know you've discussed injuries that happen mostly physically, but a member of our audience is asking, so how about mental health conditions in men and women? Mental illness is a major issue in people in general. Handling such issues is very challenging. So do you have any input on that matter?
Yeah, that's a great point. Yeah, it's one of the limitations with, I focused on kind of musculoskeletal injuries today, but there's a huge there's a growing body of literature looking at kind of not just physical health conditions but psychological health conditions. I think this is an area where one of the other professors in gender work and health, Peter Smith at Institute for Work and Health, I think he's done a bit more work in this kind of area, but what we know in the literature is that the way in which there's gender differences in the way people talk about their kind of symptoms. That so typically men are less likely to be able to speak with healthcare professionals about. They're less likely to actually seek care and seek help for psychological conditions compared to women. So that's I don't. It's not really my area of expertise. But I could definitely point people to some research which does look into that.
Absolutely, we can add those resources as well.
Yeah.
And another question, more specific one, is in healthcare or a pharma sector, as per research, what are the possible health-related issues and how do we overcome it?
Yeah, healthcare and farm. Sorry, I just want to make sure I understand the question. Pharma sector, I'm not so familiar with, but I mean, I can imagine there's similar challenges with pharma sector and healthcare in terms of kind of a lot of injuries are caused by repetitive tasks, and that's going to be impacting women more than men due to kind of biological differences. I don't know if that's something that can be addressed with sort of more automation. I don't know. I'm just thinking of like when I think of healthcare, a lot of strain injuries and things are caused by lifting patients out of beds and stuff. So there's ways in which you can use equipment to try and assist with those kind of activities. But maybe in pharma sector, I don't know if there's very repetitive kind of motions, more like with like not necessarily heavy objects, but more very repetitive activities with lightweight objects, and that can be impacting workers, and that's something that potentially that could be automated. I don't know if that helps address the question, but that's what comes to mind.
Thank you. That's perfect. Thanks, Robert. So we have a few answers in relation to the questions asked earlier. I'll just read some of the comments. So the first one is, I think it's important to increase awareness about unconscious bias, but the duty to accommodate applies to all. The second comment is interesting presentation. I wasn't aware of the gender bias in health and safety related policies and procedures. Another comment is sometimes it isn't the severity of the injury, but how the worker interprets the severity that predicts the outcome. And interesting that women don't get surgery as often as men. Not sure if it is because women decide not to get it, might be that. And then awareness to recognize that there are differences. One size does not fit all for policies and practices of workers' compensation systems. So are there any comments you would like to make listening to this?
I think they're great comments. Yeah, it's interesting thinking of like attitudes towards the severity by the worker, because I think of a kind of gender-based difference might be that a kind of maybe masculinity type of thing is that the males are less likely to, they're probably like less likely to be concerned about the diagnosis that a physician might give them. They'd be like, I'll just carry on working through the pain, perhaps. That's something to consider. Yeah, I guess the way I presented it was more in terms of the decision by the physician, but it'd be interesting to know more about the actual voice of the actual injured person themselves as well, and how that may differ. In terms of the one-size-fits-all policy, that's a good point as well. Because when I think of policies and practices, if you try and create gender-specific ones, you run into the challenge of that, like, you might not all men and women are equal, so it's kind of, you're not necessarily going to be addressing the problems which are being highlighted here. But at the same point, at the same point, it's kind of like without making sort of changes in how these things are dealt with, it's like you may just be seeing more of the same. So I don't know if introducing sort of gender and sex-based policies is going to be, it's hard to know if any of these will actually be implemented, or whether it's the duty to accommodate is for all. We're going to see these differences by sex and gender. So people who are in positions to decisions, whether it's physicians or it's people, rehabilitation specialists and things like that, they just need to be aware of the sex and the gender-based differences, and aware that there are, there's different things to consider for men and women in terms of their rehabilitation.
It is a complex issue for sure, and I'm sure more discussions and thoughts need to be put into it. In terms of awareness, as we can see from our audience, there's an obvious and evident lack of awareness, and I'm sure that it's in the general public as well. What do you think would contribute to spreading awareness in terms of those gender inequalities and bias as well?
Yeah, I think just kind of, knowledge translation and trying to get more of this research evidence out into the public. The problem with a lot of academic research, there's some great work done, but it's often just contained within peer-reviewed journal articles or books, of which only so many people can actually get access to. So I guess exercises like this kind of webinar, but also just in general, maybe trying to raise awareness among employers and workers is key. I guess that's something where, organizations like WorkSafe BC perhaps play a part as well, because in terms of educating workers on occupational risks. And so I think in terms of just knowledge dissemination, greater outreach of research evidence to try and help educate people, make changes.
Great input, thank you. So thank you so much, Robert, for showing us how sex and gender differences in work-related health can be used to improve work disability management and rehabilitation policies and practices. We really appreciate your time. Thank you, Robert. And to our audience, thank you for your participation and continued support. The recording of this webinar will be available on our website along with the slides. All registrants will receive a notification email when these items are available. A reminder that this program is valid for 1 PDC or professional development credit for the SHRM CP or SHRM SCP recognized by the Society for Human Resource Management. If you're a WWI member or a VRA Canada member, you receive free certificates of attendance. Otherwise, there's a $15 administration fee. Immediately following this session, you will be directed to the evaluation survey. We appreciate your input on our webinars, as well as suggestions for future topic areas. If you have any answers or input about those questions that Robert asked in the previous slide, you can input them in the key messages. And don't forget to visit our website at workwellnessinstitute.org and stay tuned for more upcoming webinars. All of our live webinars are accessible to the public. Thank you so much for your participation. Stay safe and take care of yourselves. Thank you so much, Robert. Have a wonderful day.
Thank you very much. Have a great day too. Bye-bye.